Dear colleagues, it is really quite some time that I have been visiting your beautiful country, and I really have to tell you that I miss you, and I really regret that I cannot be with you personally, but it is my big pleasure to actually present you this lecture. I have actually brought two lectures for you, and the one will give you an update on allergy diagnostics and in particular on some utilities but also advances regarding microarrayed allergens. Now, as we all know, allergic patients suffer from different manifestations. They occur in different organs, they have different severity, and they change by time. Upon allergen exposure, they can occur together in mixed profiles, phenotypes, combined phenotypes, isolated phenotypes. The most common one, hay fever, cutaneous manifestations, also asthma and gastrointestinal symptoms. The key step, I think, in the diagnosis of IgE-mediated allergy is always, and I think most of you will agree, the confirmation of the allergic sensitization by demonstrating the presence of allergen-specific IgE antibodies. There is actually different assays to do this, and there's the one that is the INUNIMAI assay. It's a quantitative assay where you can measure the quantities of IgE to each of the allergens and the allergen extracts. And there's also the multiple testing with chips containing microarrayed allergens, and in this review article we have considered some of the technical specialities of these different tests. I think it's very important for you to understand the differences between the two systems. In the INUNIMAI we have a large amount of allergen immobilized on the solid phase. You can see it here, it's about 1 to 2 microgram per INUNIMAI. Whereas in the microarray, we have a very tiny amount of allergen per spot. So this is a major difference. Another major difference is, of course, that per INUNIMAI you can test one serum, and you need quite a lot of serum to do this. Whereas on the chip, you have more than 100 allergen components that you can test with the same volume. Regarding sensitivity, I think in the end of the day, one can conclude that the sensitivity of the INUNIMAI and the chip is pretty the same. You can screw down the INUNIMAI to 0.1 kilo units, but in the end of the day, also 0.1 ISO will give you an important information about sensitization already. I take this as an example to introduce to you a little bit the validity and importance of allergen-specific IgE levels that you can also measure by chip diagnosis. And this has been done in this paper by Olga Ilyusyutina in cooperation with Professor Musa Kaito from the Institute of Immunology in Moscow. I think this is a very interesting paper to read because we have been determining in a group of children that had allergic symptoms to birch and children that had no allergic symptoms, but some of them already were sensitized, their IgE levels against the BAT-V1 by chip measurement. We had in the cohort of the allergic children with different phenotypes of disease, and one of the very interesting findings of this study was that actually those children that suffered not only from respiratory allergy to birch, but also from oral allergy syndrome were the ones that had the highest levels to BAT-V1, as you can see here in this figure part D, where the ORS group, the oral allergy syndrome, has significantly higher IgE levels as compared to the children with asthma to birch, or allergic rhinitis to birch, or atopic dermatitis in response to birch. Now this is very interesting because we can see that the levels of BAT-V1 specific IgE can tell us something about the phenotypes, and it basically says that the higher the IgE levels are, the more likely you will also suffer from oral allergy syndrome, for example, when you eat apples or hazelnuts or other PR10 containing fruits, and vegetables. We know from this study that I show you here from Sweden that the microarrayed allergens, PETV1 and the corresponding allergens from apple, hazel, peanut and other allergen sources that contain the PR10 proteins can be used by early diagnosis in children to predict, in fact, whether a child will become allergic later on in their age. And this is possible in these studies by the follow-up of the same children at the age of 4 years, 8 years, and 16 years, as you can see here. And the interesting finding of this study was that actually at 4 years, many of the children had only PETV1 specific IgE, these are the pink ones, whereas later on, many more of them become symptomatic. These are the ones, blue cross-hatched and white, that develop symptoms. And the important finding of the study in a nutshell was actually that when you measure the PETV1 specific IgE levels at a young age, and the children still have not symptoms yet developed, you can already predict, according to the level of the PETV1 specific IgE, whether a child will have allergic rhinitis and respiratory problems 4 years later or even at 16 years later. So in other words, it shows us that we can use chip-based diagnosis not only for telling somebody that he or she is allergic, but also to predict if somebody will become allergic based on silent IgE sensitization profiles that not yet have clinical symptoms. Now let me come to another issue, and it's a very interesting one. It relates also to pollen, and pollen can actually release particles and can behave in very interesting forms, in particular when pollen is exposed to rain. Birch pollen can in fact germinate. Grass pollen can do something different. When grass pollen comes into rainwater, grass pollen can rupture. And you can see that then the grass pollen grain releases small, what we call submicronic particles. And we know that they contain a lot of starch, but they also contain allergens. And by this, the allergen can go into the lung. Now, grass pollen is a source of important allergens, but there are some allergens that you may know in the meantime. This is FLUPY4 and FLUPY13. FLUPY4 is a part of the diagnostic test systems, which are proteins that are actually quite heavily glycosylated. And there's something very interesting that we know about these proteins, and this was tested in this study here. Although FLUPY4 is a very frequently recognized allergen by IgE antibodies, it shows a very poor allergenic activity, so it induces allergic symptoms to only a very, very low degree, as you can see here. So FLUPY4 is a potent IgE binder, but it doesn't cause symptoms. And this is because of the fact that carbohydrates do not exhibit strong allergenic activity. We have actually seen this very clearly when we were testing a population from the Philippines. It's a tropical area where many of the investigated patients had actually IgE antibodies against FLUPY4. But the interesting thing was, when you look then whether they have symptoms or not, you can basically see that the IgE activity is the same in the symptomatic and asymptomatic people. And this paper tells us that IgE sensitization to carbohydrates is without any clinical relevance. Now, why is this important in IgE testing? It is important for IgE testing because carbohydrates can confuse us quite a lot. We measure IgE, but we cannot be sure if the patient really has symptoms. Carbohydrates are present in many different allergen sources, in venoms, in plant parts, plant food and vegetables, and in fruits as well. And the problem is that when we have carbohydrates in our tests, they create a positive IgE reaction, but very often the patients have no symptoms, and then the diagnosis gets confused. It has been suggested that carbohydrate markers can help identifying these patients, and in fact they really can do. We have developed such a marker that is described in the paper by Beer Gattinger. And you can see here, when you use an immunocap ISAC and you preincubate the serum with the CCD marker, you can basically extinguish the IgE activity against the SYND1 that is glycosylated and against the FLIP4. You see here on the left side, FLIP4 reacts with IgE antibodies. When you pre-adsorb with the carbohydrate marker, the IgE activity completely disappears. Well, this is, looks nice in this experiment. However, it does not work with all the diagnostic tests that are offered. And there is currently a couple of them on the market. And when you test in these systems, in some of them, carbohydrate markers are used to pre-adsorb the serum. But nevertheless, you can see that the addition of the carbohydrate markers actually does not completely extinguish the reactivity even to the carbohydrate marker itself. You can see it here. This is the carbohydrate marker. And blocking with the marker does not extinguish the signal. So in other words, the pre-adsorption does not help. What you need a test where you have no carbohydrates in it from the beginning. That means there should be no glycosylated allergens in the test system to give a clear result. And this is why I recommend to test with systems where you have non-glycosylated allergens and do not make the attempt to inhibit with carbohydrate-containing materials. It will, in most of the cases, be incomplete and lead to inconclusive results. This also plays a little bit in the resolution of complicated cases, and some of you know this case of the boys that have been seen by Elena Fedenko, and one of these boys actually suffered from very severe food allergy and atopic dermatitis, and in fact, when tested with allergen sources, responded to most of them, although actually the boy had very specific sensitizations. The problem was that when tested with IgE tests that contain the carbohydrates, it was very difficult to find out the really sensitizing sources for this child. And this was only obtained when the boy was tested basically with the ISAC immunocap technology. And there you can see the boy has a very high carbohydrate reactivity, and only the testing with the non-glycosylated allergens then reveals the sensitizations to the many food allergens in this boy that then led to the prescription of a diet that led to relief of the symptoms. So be aware of this, and if you can, please use IgE test systems where there is as little as possible carbohydrates in it. Now let's turn to one of the big strengths, I would say, of molecular diagnosis, and this refers to the prescription of a very important form of treatment, and this is allergen-specific immunotherapy described here in this position paper, a therapy that is given since 1911 with big success. And the advantage of specific immunotherapy is, first of all, that of course it's quite cheap as compared to biologics. It's highly specific for allergens. However, you need to identify the causative allergen source to prescribe the correct treatment. The treatment is effective. It modifies the course of the disease. It's long-lasting. And I think what is very attractive, it's more effective than pharmacotherapy, more effective than steroids and also antihistamines, because the effects that you can get in individual patients is about 50% over placebo, and you will never get such an effect with an antihistamine or a steroid. However, you have to do a correct prescription. And in order to prescribe the correct vaccine, I think it's very useful to test for components and molecules in the sensitization. So the second thing that I think is very important is that you are able to monitor also the development of the allergen-specific protective IgG response. It is a little bit like with the vaccination against COVID. Now people become vaccinated and they develop antibodies, but the problem is not each of them is really protected. We see many people coming to us and they ask, now I had COVID or I was vaccinated. Doctor, can you please tell me if I'm protected? And for this, you need to measure the protective activity of the antibodies. Now in COVID, you can do it by blocking test, and I will show you later. In allergy, you can do it by measuring the blocking activity of the IgG antibodies. And this can be done in an old-fashioned way by looking at the reduction of the skin prick test reaction, which will decrease after successful immunotherapy. But you can also do it by an in vitro testing using microarrayed allergens by looking at the reduction of Ig binding. And I will explain you how this works in a minute. But let's stay now with the prescription. Now, especially in house dust mite allergy, but also in other allergen forms, it becomes very important to test the patient before prescribing the treatment. You can see there are certain allergen extracts, house dust mite extracts, that do not contain certain allergens, like for example, TRP5, TRP7, TRP21 are absent from this extract or from this one, or from this extract, and many of them are negative for TRP23. Now what we can expect is that actually people who are treated with such allergen extracts lacking TRP5 or TRP7 or TRP21 or TRP23, they will not be protected against these allergens. They can only expect to have protection against TRP1 and TRP2, and then you may expect they have a worse outcome in the immunotherapy treatment. Now, one of the recent publications that looks into this topic actually confirms this, and I recommend to you to read this paper by Azahara Rodriguez Dominguez, published in the Journal of Allergy and Clinical Immunology. It's open access, you can easily download it, so it's paid and you can view it and you can read the article. And in fact, this article shows, and this is summarized in this slide here, that actually people who are sensitized to TRP5, TRP21 or TRP7 or TRP23 have a worse outcome in the reduction of the combined symptom medication score as compared to subjects that are positive mainly for TRP2 and TRP1, as you can see here. And the reason for this, and this is explained in great detail in the paper, is that these patients do not develop TRP5, TRP7, TRP21, and TRP23 specific IgG antibodies. So you get only a partial protection by the treatment. And the paper says you should look actually in your patients and select the right ones for the treatment, because not everybody will respond to a vaccine that contains only TRP1 and only TRP2. The other thing, and this is more fundamental, is the correct prescription of the allergen extract. You know, we have cross-reactivities between grasses, olive pollen, also wheat pollen, especially in Kazakhstan, but also in other countries, where all these wheats flower. And this paper by actually the group of Joachim Sastre shows that molecular diagnosis to select the patients, to give the right vaccine, to give the grass pollen vaccine only to the grass pollen sensitized and not to the birch pollen sensitized, is a very important thing when you start the immunotherapy. For this, we have molecular tests, and it's quite clear that only the BAT1 positives should be treated with a birch pollen vaccine. Only the FLIPI1, FLIPI5 positives should get the grass pollen vaccine. And you can extend this decision tree to mugwort, to ragweed, to olive and baritari and other weeds. So it's a very important way to properly select the immunotherapy. However, having selected the right patients for the treatment does not yet mean that you will be successful with immunotherapy, because not all of the allergen extracts have a good quality. And this is why we recommend to measure the development of IgG antibodies after a few months after starting of the treatment, for testing the development of IgG against major allergens. And what we argue is that if a patient does not develop IgG antibodies during treatment, the chances that the patient will benefit from the treatment is rather low. Now, the beautiful thing is that you can all these with allergen microarrays. You can also buy immunocap that measures IgG, but the best thing that you can do is that you use a microarray. And you see here an example of a patient who received grass pollen immunotherapy. Actually, here is shown the IgE activity against the grass-borne allergens before the treatment. And you can see after treatment, this IgE activity is reduced. When you compare T1 with T2 and T3, the signal gets lower. What is the reason that the IgE signal here decreases actually at the visit 2 and the visit 3? Well, the answer to this is that this patient develops IgG antibodies against the allergen and also IgG4 antibodies, as you can see. And what happens is that the IgG1 and IgG4 antibodies, if they are induced against the right epitope, will compete with their IgE, and this will lead to a decrease of the IgE signal. So the chip is a beautiful tool to study actually the effects of immunotherapy. How is this possible? It is possible because when you add competing IgG antibodies, the IgG can compete with the IgE binding and reduce the IgE binding in the chip-based testing. You can see here the decline of the IgE signal, the more of the competitive IgG you dilute and titrate into the serum. This cannot be measured, as you can see here in the immunocup. And the reason for this is explained in this picture. When there is a lot of antigen present, like in the immunocup, the IgG and the IgE can bind at the same time because there is enough allergen presence. However, when there is a relatively little allergen present on the surface, like it is in the chip, the IgG in blue can block the IgE away, and then you get the reduction of the IgE signal. Now, this is something very unique that you can only measure with the immunocup ISAC. So it's really a very big advantage. Now I summarize here what we can do now to avoid or at least limit the failure of immunotherapy. Well, first of all, let's do molecular diagnosis to select the correct vaccine to address the patient sensitization profile. Secondly, let's look if there's IgG developing, and in particular, let's look at blocking IgG by measuring the IgG binding by microarray in the course of the treatment. When the IgG binding gets lower in the course of treatment, the patient is on a good way, and I highly recommend this to you. Now, of course, we all know that microarray-based testing is quite expensive, and it also has some disadvantages. Many of you will be reluctant to use it in each of your patients because it's very hard to afford it. And the question is, how will this technology actually develop now? And what are the next steps? Now we have looked into this, and you can actually read it in this article in Frontiers of Immunology. That is, by the way, also freely available. You can download it and you can read it. We paid for it so that everybody can read the contents. Just go to it, click it, and read it. Now, what are the needs that we have in microarray-based allergy diagnosis? Well, I think a microarray is as good as the library of allergen molecules and peptides that are on it are in the quality. If you have bad molecules in the chip, actually the chip will not be very useful because, for example, when you have carbohydrates, what will happen is that you will get a foggy result and you will not know if the sensitization is clinically relevant. So we prefer chips and microarrays with high quality protein allergens where you measure really IgE activity to clinically relevant allergens. So the quality is important, but there's another thing, and this is the versatility. We would like to have the chips for hand pipetting, but others like to analyze large quantities, numbers of sera, and then they would like to go in a laboratory and they would like to have an automated version. Now there's also room for improvement. Of course, we get a lot of information by chip testing, so we need interpretation for decision making. We need different formats of the chip to address different needs of the analysis. Some like to have a chip where there is only one array for one testing that can be done immediately and read immediately. Some prefer to have several on one, and some prefer to have an automated version. And then, of course, the whole thing should be affordable and it should be not too expensive so that every patient can benefit from it. Now this is how we think the future looks like. You can see here a completely new format of allergen chips. They are very shiny. At the moment we print these chips in our laboratory, so these are prototypes. And you can see what is the first difference. It's not a nitrocellulose, it's not a glass. We use as a surface a material that comes actually from the computer industry, and it's silicon. There is a lot of advantages of silicon. I will show you then. First of all, the silicon chips are much more sensitive, 10-fold more sensitive than the glass slides that we use at the moment. The other thing, and this is what you can see here, here we have an array that contains 1, 2, 3, 4, 5, 6, 7, 8 inserts. So there's 8 microarrays inserted in one chip. You can test 8 sera with this chip. However, you can also use the insert and produce chips with 3 or 4 or only 1 insert, or you can insert the microarray in another format. So it's very versatile. Now what about sensitivity? You see here, always in red, the silicon slide, tested with many different allergens, terp1, terp2, terp8, you can see it here. Feldi1, for example, betwi1, RH8, many different allergens, and always you see the same. The silicon slide is more sensitive when you dilute the serum than the glass slide, and surely more sensitive than, for example, a nitrocellulose-based assay. And it works, as you can see, not only for IG, but also for IgG detection. As you can see on the right-hand side, and also here, it is much more sensitive. The second thing, and this is what we think is really the great improvement, is that I can have the silicon array in different formats. I can make you a chip that contains 1 array for testing 1 patient immediately to be scanned easily with a very easy device. I can have 8 that I can do by hand pipetting, and I can insert the slide basically in a plate, and I can put it in a machine to read it by a fully automated processor. And then I have a fully automated version so that I can process hundreds and thousands of sera if I want. The other advantage, of course, is that the printing is fast. Little material is needed, so the array is quite inexpensive. So I think there's a lot of advantages. Now this is basically what will, I think, revolutionize allergy diagnosis. And then we can have microarray diagnosis for each and everybody. And what is the advantage? You have basically 1 consultation with the complete microarray result, and you can immediately come to a more or less final diagnosis. So you have 1 visit in the presence of the IG reactivity profile. You make your diagnosis and you make the recommendation for treatment. And this will change the old system of traditional diagnosis, where you start, you have a visit, some provocation testing, some IG testing, and then the patient needs to come again and again until you reach the final diagnosis. It's very frustrating for the doctor, but also for the patient. By the way, the fast system with the microarray, when you link it with telemedicine, will allow basically to take the chip result in a remote area of your country by a home doctor, send it in a laboratory, and then you can send the result to a specialist sitting somewhere completely in a different place that gives a treatment recommendation, a fully allergy professional that can then look at the anamnesis and the IG reactivity profile and give you a teleconsultation. So it will reduce the need for the mobility of the patient. Imagine you're in a big country. Patients do not need to travel anymore because the results are collected on the spot, and then they are revealed to a specialist, and this one gives the diagnosis. So I think there's a lot of things coming to us that will improve the management of allergic diseases by improving actually the diagnosis. Now let me end you here, and I do it with some sad feelings because I cannot visit you. But nevertheless, what I can do is I can send you very heartily and cordial greetings from Vienna. And I put here 2 images from Vienna, from my place, that should remind you where I'm sitting and from where I'm sending you my greetings. This is Schönbrunn Castle with the tulips in front. And this is the Vienna Prater with the giant Ferry wheel, where basically the trees are starting to flower already in our country. So here are my greetings and all the best to you, and stay safe. And I hope to see you soon in the near future. Bye-bye.